Good afternoon, innovators. David Wright here, coming to you live from HIMSS 2026 in Las Vegas with a very special episode of Disruptive Innovators. Over the course of the last 2 days, I've had the great privilege of being joined by CIOs, digital health leaders from around the country, discussing their challenges, things they're aspiring to, how they're using AI, CMS, access to care, and everything in between. These conversations are short, but their perspectives are invaluable. Think of this episode as a snapshot of the moment we're in right now in healthcare innovation, captured directly from the people helping shape what comes next. So with that, let's get into the conversations. Good afternoon, innovators. David Wright here, and I am your host of Disruptive Innovators Live, coming to you from HIMSS 2026. Grateful for our sponsor, Lumen, and I'm joined here by my bruv, Tom Boyle. Tom, pleasure to have you up.
Likewise, mate. Nice to see you.
You all right?
Yeah, not too bad. Little British accent coming in there.
I'm trying. So yeah, I'll be out that way in a couple of weeks, but glad to have you over here. Tom, for any of our listeners who might not be familiar, do you mind just sharing, 30 seconds about your current role?
Yeah, so head of digital comms at a large acute hospital in sort of the Midlands in the UK. 5 acute hospitals, got about 30,000 staff, a couple of million outpatient appointments a year, all adult care as well. So I look after CX, telecoms, audiovisual, patient booking, so contact centre, switchboard, all sorts of weird and wonderful analog stuff as well, paging, all that sort of classic stuff.
Of course, yeah. I'm excited to get into that a little bit. I got a couple questions for you about how that translates. But before that, I mean, we have the 10-year plan in the UK, things shifting with, ICBs, integrated care boards, and integrated neighborhood teams, trying to avoid the acronyms. But in your perspective in the NHS, what are some of the biggest digital priorities for, and even just for NHS trust right now?
I think it is a bit like what I'd said, looking after a load of sort of analog stuff. It's like that shift from analog to digital, in all honesty. Yeah. I think that, against the face of massive sort of backlog that we've got in elective care, so we've got a huge waiting list, really long waiting times for patients, and we're not very good in staying in touch with them and being proactive with it. Yeah. And people in the UK, you'll have experienced when you're there, is that we don't mind waiting, we'll queue. Yeah. But as long as we know what's happening.
Right, big on the queues.
But when you don't know what's happening, you get anxious, especially with care, because it's emotive. And so that for me is the biggest one at the moment, is that I think people are accepting that they're going to wait longer for treatment, but we need to keep in touch with them. We need to keep them on the side, give them that patient experience piece that we don't at the moment. Right. And then ultimately that sort of shapes perceptions of care. There's a lot of research in that as well. And people then, if they have a good experience, they don't mind waiting, dependent on the care that they get in the end anyway, they're going to think it's really positive regardless if they've had a good experience. Right.
Yeah, like how are you managing expectations, basically?
Pretty much.
So shifting gears a little bit, I've been kind of walking around here. Clearly, AI is everywhere here at HIMSS. Where do you see real, practical use cases in the NHS versus just hype and kind of fodder out here?
Yeah, no, we do that. We do that sensationalized piece as well in the UK, in all honesty. It's the press is AI is going to cure cancer, just go straight into that. I think it's all the low-hanging fruit, in all honesty, all that sort of monotony. Right. All that sort of clerical work that we don't necessarily need to be doing, that we can get AI to do the heavy lifting for. Yeah. I think there's loads of potential there. I think in my case, thinking about what I look after, sort of chatbots, dealing with the real churn of requests that we get in, that'd be great. From a clinical perspective, I think there's so many use cases. Radiology, sort of scalping through scans, through imaging, picking up on patterns and then passing the ones that really need to be seen to the clinicians. That in itself is going to save time. But yeah, it's that real basic admin churn that we need to work on first.
Yeah.
I think that'd get people on side as well. Then if we can get that done and make a start there, then we can think about curing all these terrible diseases. But if we start with the extreme and work backwards, we're not going to get anywhere.
Right. Yeah. I mean, there's a lot of low-hanging fruit here, so that tracks. So have you? We talked about it. So you haven't been to Vegas before, right?
No, first time in Vegas.
And what about in the States in general?
Pretty much just Orlando. Big Disney fans, me and the wife.
Yeah.
Yeah, we've been. My wife used to go when she was younger, and then that turned into we've been like 7-8 times together. Been with the kids
To Florida.
to Florida. Yeah, we were here in September. No doubt we'll be back when George is a little bit because we just had a baby.
How about for and yeah, congrats on that.
You too, man.
Yes, but you were brought over here by a vendor,
Yeah.
And I imagine like you've been kind of drinking through the fire hose, like just like in learning about U.S. health systems. And I know we've had conversations too, but so you're here at HIMSS. Vast majority of folks here are U.S.-based health systems. What are some differences that stand out to you between, how the NHS and U.S. organizations either approach digital transformation or operate, or any like things that have stuck out to you as you've like watched any of the panels or anything like that?
I think it was perhaps a naive perception, but I came out fully expecting, because of the commercial model that you guys have got out here, I thought that would translate into you being millions of miles ahead of us because it's competitive.
Right.
I thought that competitive nature would mean that you'd want to be ahead of your rival organisation down the road.
Right.
But it doesn't seem to be the case. There seems to be more parallels than anything.
Yeah.
Which is bizarre. I think a lot of people that I've spoke with as well have talked about organisations upscaling and taking over organisations. That's similar to what we've got in the neighbourhood working model.
Right.
Is that whilst it's not competitive, it's that we're sort of seeing organisations merge, and then that means that there's big projects from a CX perspective that involve sort of mass sort of groupings together. So there's actually more similarities than I expected, which I am surprised about. I was expecting there to be massive parallels, but it's the same conversations here as I would like we'll have in Rewired back in the UK in a week's time, like there'd be at HET. Yeah, real similarities in all honesty.
Yeah, no, I mean, I saw a lot of the same things. I mean, there's differences, obviously, being a, single payer kind of, government sponsored, healthcare delivery organization versus this kind of democratized.
The concept of customers and patients still blows my mind though.
Yeah.
Like, I'm speaking to people about the customers, and I was like,
yeah.
right.
But yeah, I would tend to agree, especially, I mean, you mentioned kind of the M&A activity that's going on per the kind of macroeconomic trends we're seeing in the United States, where health systems, in order to keep up with the pressures that payers are putting on them, need to grow and need to scale, and the ones that they're acquiring couldn't withstand the heat by themselves. Whereas, different but similar in that things are coming together. You have a patient in a given geographic region in the UK, and those regions are shifting too, like where the lines are drawn or not. But those trusts are needing to come together to figure out how can we deliver care in a seamless way? How can we communicate data without there being these chasms where,
or even just give the perception of it. That's translated a lot in all honesty whilst I've been here, is that people have been saying that they've obviously been buying out smaller local hospitals.
Right.
And forgive me for knowing the sort of phrasing here. Yeah. But they're sort of buying them out, but then there's nervousness from patients or customers because they're really familiar with this smaller sort of company that they get their care from.
Right.
But then they're nervous that they're going to have this big conglomerate come in and they're going to sort of really industrialize it. So that's similar to what we've got in all honesty, which is, just different terminology and a different commercial model, I guess.
Yeah. And I think my experience is that regardless of, whether it's, that scenario where it's like, primary care practices being brought into a health system, or even an acute care facility, whatever, being brought into a larger organization, and maybe that kind of access function is being centralized. If I can make the experience personalized, compassionate, and radically convenient, like if I can hit on those three things, people will typically lean in. Maybe they're not talking to Susie, who they talked to for the last 20 years or whatever it is. But if I can achieve that experience, they will find it, of value. Yeah.
No, I'd agree. And there's the one thing that I have got from being here is that there's a lot of comparisons to retail, back home at least, is that even if you take a pizza, you're probably going to buy the pizza from the place that's going to let you know that they've got an offer on. They're going to let you know when you buy it and when it's being baked and when it's ready to collect.
Right.
And it's the same sort of thing that we're trying to do in CX, I guess, is that you've had a referral, you sat waiting for the referral, you sat waiting for the appointment. If we can do it in retail, why can't we do it in healthcare?
Yeah.
Well, that's what I've been toying with back at home, in all honesty. So that was what I was hoping to try and get some ideas.
Funny story. My friend Joy was responsible for the creation or part of the team that created that tracker for Domino's, which is
that's the analogy that I use all the time.
And now she works for a health system in the US, right? We saw some of that too, where health systems would get either people from retail or hospitality because, there's something to be said for a fresh set of eyes, right? And that was my experience too when I went to visit with some of the trusts, on my last trip, was like they were just kind of happy to have a fresh set of eyes. As long as, as long as we came at it from a place of humility. I think that was also like a big thing. It's like, no, like we don't have it figured out either. Like we're all kind of trudging the path here. So as a advisor or whatever you'd say, like, let me not come in with this attitude of like, oh, I know. Like, let me say like, hey, these are the problems I've solved. These are the things that I've learned. What of this translates? And, how can we, work it into where you guys are going, right?
No, 100%. And back to what you were saying about sort of execs moving from retail to healthcare, is that I've read a book at the moment, exactly that. Disney exec moved to healthcare, sort of the whole sort of Disneyifying of the approach in healthcare and the CX piece. And I think that you guys do that better out here anyway, but there's no reason that we can't be doing the same.
Yeah.
And maybe there's a lot to learn, a lot we could learn from industry, but we're really nervous about that in the UK because there's this sort of private sector and public sector, and we don't want to cross in case it looks like it's going to be privatised, but we're going to have to do something eventually.
Yeah.
Or people will go, the more and more people are going to go and get private healthcare in the UK. My fear is the primary care docs are just going to go the way of the dentists and just do their own thing. Anyway, so this has been great, Tom. I mean, one of my last questions for you would just be like, if we were sitting here again, HIMSS 2027, having this conversation, what would you hope has changed in healthcare technology? Or maybe like, what are some of the things that you hope to see happening within Sheffield even? I think that I'd like for us to be in a better place with being more proactive in staying in touch with patients. I think that it would reduce the volume of the call traffic.
Yeah.
It would reduce the burden on the clerical staff. We can then reuse their time to be doing stuff that we're not doing at the moment. Staff would be happier, culture would be better, patients would be happier. I think that in itself, I think there's so much to be said for it. But because you can't sort of put a value against culture and it's really difficult to measure patient experience, I hope that we're not sat in a year's time when we're still in the same place. But I'm positive about it. I think that we can get there. I think that the vendors, suppliers just need to maybe stop so much. I'm not saying that they're going to stop selling, but stop selling the technology and really try and understand sort of the operational pieces that we've got going at the moment. Yeah. When they understand the needs better, I think then they can fit the technologies instead of the other way around.
Yeah, I mean, even just what you've been talking about today, like, has my wheels turning as to like, I did this whole thing for, follow-up care for TBI patients years ago at the National Academy of Science, Engineering, and Medicine here in DC. And, how do you keep that tether, right? And so anyway, it's just good to be in the question about it. But now this has been great, man. Thank you for joining us.
As always, man.
Yeah. To our listeners, thank you for tuning in, and we'll catch you next time. Good afternoon, innovators. David Wright here, host of Disruptive Innovators, coming to you live from HIMSS 2026. And for one of our last sessions on the last day, I am lucky enough to be joined by my friend Tonya Reeder. Tonya, it's a pleasure to have you on.
Thank you for having me. Hey, everybody.
Yeah. And, Tonya, for any of our listeners who may not be familiar, would you mind just sharing a minute about your current role?
Cool. My name is Tonya Reeder. I am the Chief Information Officer at Walter Reed National Military Medical Center, as well as the Technical Advisor to the National Capital Region market.
Wow. I don't know if I knew about the second part. So, and Tonya, unfortunately, I've been trapped up here in the top floor of this hotel, hosting
Which is
a lot
not
of.
a bad place to be.
It is not. And I've actually had just one after the other, just amazing conversations, which has been, a gift. But I unfortunately missed your panel here that was just a few minutes ago, actually. Would you mind just sharing with me a little bit about what you spoke about?
Okay, so what we were talking about, it was specifically about people of color in the C-suite and how there's not many of us there, and just basically had an honest conversation about what it means to be there, how do you get there, and how do you deal with challenges once you're there, as well as the trajectory to get there.
Wow. I mean, such an important conversation.
For sure.
Did you guys talk at all about what someone like myself can do to support in that, or be a contributor rather than a detractor? Because I feel like in these conversations, a lot of the times, there's some education that's required.
Yeah. So one of the things that people who are not of color can do is, number one, don't tell us who we should be, right? Who we should be, who we are, what you think we are, right? Listen and understand our perspective. Also understanding that sometimes, and not even sometimes, majority of times, each of us, whether you're a person of color or, I don't hate to say average because we know you're not average, but a white man.
Average white man.
Woohoo! Knowing that our experiences are different, and understand what that experience is, right? So don't see me, or don't judge me as a person of color, judge me on my merits, which is funny to say that because that's what we expect people to do, right? But see me that I have a bachelor's degree in nursing, right? I have a master's degree in healthcare administration. I have a master's degree in business administration. I have a master's level certificate in informatics.
Right.
And, oh, by the way, I've been a ICU, ER, and trauma nurse for 10 years before I transitioned into IT. Right. And I worked my way through IT. I didn't get here because I'm cute, even though I am.
Yes. Oh, man. That's well, I'm so glad that HIMSS is hosting that conversation, first and foremost. So happy to hear that. Separate and apart from your panel, curious, so you've been here since Monday?
Yes, Saturday, actually.
Oh, wow, yeah. So what are some of the biggest themes that you're taking away from the conference, or was there another panel that you saw that really spoke to you? What's some of the more pertinent or pragmatic things that you're taking away from the conference this year?
There's been obviously a lot of conversation about AI.
Sure.
You can't walk past two vendors and not touch someone or see someone who's advertising AI, right? So number one is everybody wants to do AI, right? Not many people know what AI is.
Yeah.
Not many people know how to utilize AI. Not many people know the difference between the languages in AI and how you train AI and how do you take out the inherent bias in AI, which I think is important.
Yeah.
in addition to, once you sell me this great AI tool, how are you going to help me to utilize it to its greatest function? If I'm giving you $25 million and I'm only using $1 million worth of the functionality, then that's a waste of my time and a waste of your time.
Right. Do you think there's like certain models like are inherently more racist than others?
I don't want to say racist because it's really not racist,
Right.
right? The reason I'm using the word bias is because it's based on the data and information that's used into it.
Right.
Right. So let's think about this. Let's think about utilizing AI specifically in healthcare. All right.
Okay.
And we could even use military healthcare.
Yeah.
Right. When you talk about the early days, and I'm talking like World War I and so on and so forth, a lot of the African American, Asian American, Indian Americans data is not in the military health system. Not because anyone, I'm hoping, was trying to be negative, it just wasn't there. So when you train the model of how do you take care of a military health or a military beneficiary, that information isn't in there. So you can't treat me the way that they would treat you because the baseline information is different. Does that make sense?
It does.
So it's not racist, the information's not there.
Yeah. My mind went to like Grok or like other things like that. But that's a good answer to an interesting question. So I appreciate that. So another question I had for you. And how long have you been in DHA as a CIO?
So I've been a CIO for about 4 years, but I've been in. So first it was military health system before we transitioned to DHA.
Got it.
But I've been in the Fed space for 18 years now.
18 years. So you've been in the Fed space 18 years, CIO for 4. What are some of the biggest challenges that you face in your role today?
Biggest challenges I face in my role today. I hate to say it, but it's the same as every other day in any other time. Do more with less.
Right.
And we want you to build the Eiffel Tower, but we're not going to give you people, time, or resources, finances to do it. But that's in any organization, right? They want the greatest thing, and you have limited resources. So you have to be very creative of how you provide that the functionality and the benefit for the end user.
But I would acknowledge that that's compounded by the regulatory environment in a government, entity where like what you can access or how you can access it, it's just, I could only imagine that it's tricky. But all that said, what are you optimistic about, or what are you excited about coming? You've come here, you've heard some of these ideas. In the next 6 to 8 months, what are you most excited about?
The innovation, and I hate using that word innovation because everybody says innovation and AI. Those are two of the bad words in my mind. But the way that we're going to evolve the type of healthcare we provide. So if you think, well, I'm not sure if you know, but in China, they have 350 million records. And they utilize that to train their AI models. So now you don't have to go to a provider. You can actually go to a doctor kiosk, put your hand in, and it'll tell you what the problem is, and give you a diagnosis. And they said, again, just reading the data, it's like 95, 98% accurate.
Wow.
And if it's something that the kiosk can't do, it'll tell you to go see a doctor. And that information from that kiosk actually goes to the doctor that it refers you to.
That's great.
So how awesome would that be?
That's amazing.
Right? Especially for someone like me. I hate going to the doctor, right? I'm a nurse. I know what's wrong with me. And if I don't know, I'll go to Dr. Google and figure it out there, right?
Well, yeah, we were talking to Dustin Hufford earlier today about like CMS and how they're looking to collate, a more comprehensive record of the patient, because there's sometimes data that lives outside even like an individual's core EHR data, right? It's a doula they saw, it's a behavioral health provider, it's whatever, and in being able to collate all that data, and I can only imagine historical data, kind of like you were saying, like that you didn't have those records from all those years ago. what agentic AI can do now in diagnosing disease, given feeding it textbooks on textbooks of medical dictionaries and all of that. I mean, I think 95 to 98% is not, I think that makes
That's nothing
sense.
to sneeze at,
Yeah.
right? It's pretty awesome, yeah.
That's pretty amazing.
And especially when you have the longitudinal record of everyone,
Right.
right?
Right.
And so it's obviously that's different in China than it is here in the States.
Yeah.
But the fact that they have the corner of the market to have all those records is amazing.
Truly is. So I know another thing we were talking about earlier was like, so you've noticed some more young people around HIMSS, which I think is perhaps like a newer thing versus last year or the year before. Talk to me a little bit about that.
So definitely seeing more young people, and maybe because I'm looking for them now because I'm getting older. But in previous years, it was people who were baby boomers and the early Generation X, because I'm late Generation X, so to speak. But to see them going around and bright-eyed, and they're learning, and they're actually having conversations about the information that they're gaining is amazing. Because I can think back to when I was in my early 20s, I don't remember doing that. I don't remember not just gathering the information, but also trying to determine how can I implement this in my organization and asking the hard questions.
Right. Well, and it's interesting, like what you're talking about right now, it gets me thinking about the evolution of the roles that we'll see young people play in healthcare, in technology as AI evolves. Mm-hmm. So, right, like how am I, going out into the world and having these conversations and becoming dynamic in my strategic thinking and in my problem solving ability, and like, because AI is going to be able to do a lot of the blocking and tackling, right? So it's like, okay, given that, what else am I doing? Yep. Right? And I think they're like, with the community that we have here, there's a lot of knowledge that, institutional knowledge, just tribal knowledge that people like yourself, people like myself can impart on young people, right? That can just help them grow. And I mean, that's really exciting.
Yeah, I love it.
We need more of that at Channel Partners next month. So we'll see. We'll see what happens. But Tonya, it's always a pleasure to speak to you. And thank you for taking the time today.
Thank you for having me. I appreciate you.
And to our listeners, thank you for tuning in.
Thank you.
Good afternoon, innovators. David Wright here, and I'm your host of Disruptive Innovators, coming to you live from HIMSS 2026. And for this session, I am lucky enough to be joined by none other than Trip Humphrey. Trip, pleasure to have you here.
Yeah, thanks for having me.
Absolutely. I know you were thrust into this, so I...
It was pretty recent. Yeah, just invited. Hopefully I can, live up to the invitation.
Oh, come on, man.
Yeah.
We're all friends here. All trudging the path of, healthcare innovation. So, yeah, no, it's great to have you. Trip, for any of our listeners who may not be familiar, I know you're a chapter president and you're very involved in HIMSS, but would you mind just sharing a little bit about yourself and your current role?
Sure. So I'm a chapter leader. I'm in not a president yet, running, I think, and nominated. But yeah, looking to continue the responsibility of being in the chapter leadership. I'm currently filling the role of AI SIG chair, which is a special interest group. And then we also do, I have a communications chair role. So participate in a lot of ways. I've been in HIMSS in one way, shape, or another for, I was just trying to calculate it, I think 13 years now. So wow. It's been a major influence in my career trajectory, and I know a lot of good people through it. So this is icing on the cake sometimes, just to come to these events and get to see them again and learn new things.
For sure. And you're at Carilion Clinic, right?
I am at Carilion Clinic. I'm the director of data science and AI there. We partner with a lot of different teams throughout the organization, but really just these days trying to wrangle in all of the activity and action happening in the world of AI. Data science being a part of that, but obviously just any of our platforms. I mean, just in the last few days, we've seen new announcements from Epic and Workday and ServiceNow, and I mean all of our partners there at Carilion and just all the other vendors here. They're just constantly coming out with new AI features, and so it's quite a task these days to keep.
Oh, 100%. I mean, even in disruptive innovations world of customer experience optimization, keeping up with the new features and functionality that vendors are rolling out and what's possible even to build on our own. I mean, it's a full-time job. I mean, hence the title, I suppose.
Yeah, the build versus buy, it's been, I mean, that phrase has been tossed around since before I was a air quotes leader in healthcare IT. I was here when we first started implementing Epic at our health systems, and my previous employer, I used to work at Bon Secours, and now which Bon Secours Mercy Health.
Right.
And yeah, I mean, the build versus buy concept is getting turned on its head again, right? So it was turned on its head when we started seeing legislation come out that sort of really incentivized consolidation of platforms to implement these large EMR platforms. Now we're seeing it turn on its head because of the ability with which small teams or even single members can now build software from scratch in record time. It's really amazing, and it's going to be something that I think changes the way that providers, and probably is already changing the way that payers and other participants in the market are engaging in work.
Yeah, actually, it's funny that you mentioned that. So yesterday I was catching up with Dr. Michael Hasselberg, who's now at Nebraska Medicine, and they've developed, I think, like 20 plus different AI kind of programs that they've deployed. I built off their like kind of core AI platform. Are you guys currently developing like in-house? Is that something that you're working towards? The reason I ask is because a lot of health systems in our community, they don't have huge dev teams, and with the advent of AI and what's possible with small teams, kind of like you mentioned, they're starting to walk down that path, like particularly a lot of the academic health systems that have the potential to kind of have feeder from university or otherwise. Where are you guys at on that journey?
So I think it's really important to distinguish a little bit between model development and bespoke model implementation or AI implementation. Model implementation development from scratch is a tall order, right. And it takes research and time, and it's got to be done in very diligent ways. A lot of the topics that people really, and rightfully so, spend a lot of time talking about, like the ethical development of AI, responsible AI, transparency in AI, those all really resonate with the research and design component. They obviously have other impacts in other areas, but when somebody's designing from scratch a model, what we call now in generative AI, a foundational model, or in a predictive world, a predictive or forecasting model, you're you're trying to build that model ethically and responsibly. And that takes a lot of research, it takes a lot of peer review, it takes oversight. And so that's something that I think academic institutions do a really good job at. We have a good partnership, and we have a research team at Carilion Clinic that does a lot of research, and we let that side sort of sit separately from where we then go and implement AI solutions. So I wouldn't say we're not doing it. It's just not certainly the thing that I spend most of my time trying to wrap my head around. Right? What we're trying to do is, let's say those models do generate amazing innovation, and we want to figure out how best to implement them. We have to come up with methods and controls and the danger word, governance, of making sure that everything flows in and we can just handle the influx of all these tools. And we do that in a lot of different ways. So the custom aspect, which is sometimes a bad word, but the part that we really spend a lot of time developing is the application. The implementation science of it is how do we put these tools in our team's hands in the way that they do work.
The operationalizing
of it. And I think that is unique to every healthcare institution to some extent. The more consistent you can make it throughout your institution, the better. But I think every healthcare organization has their own trials and tribulations of what does it mean to implement a protocol set here or an alert here. And that's what we partner with. So we leverage the tools within our EMR, which happens to be Epic. And we'll do the same when we start operating those same agentic or AI functions outside of the clinical space operationally when we're talking about ERP operations or service operations, in ServiceNow or other platforms. That science is largely the same, whether it's clinical or not.
Right.
So, but yeah, that's where we do a lot of our development work.
Yeah. No, that's super cool. I'm learning things on the fly here. And and what would you say are the biggest challenges that you and your team face today?
Oh, I mean, they're numerous. So I have to pick some because we want to end sometime today, I imagine. But there's a lot. The chief ones are the ones everybody hears about. Governance is super important, and legislation is getting written differently by each state.
Right.
So each state has a different path to walk there. And then at the federal level, there's different controls being put into place. I think that's that whole governance component, legal, privacy, compliance in an institution is important. And threading that needle in an elegant way that allows innovation to happen and allows disruption to actually still occur in a helpful way without the disruption that isn't helpful, which is like legal disruption, like court cases. Right? We don't want any of those sorts of disruptions to our work. Right. We want positive disruptions, innovative disruptions. And so I think the goal is to sort of take that and just keep doing the hard work. And it is hard work and it's boring work sometimes. And I think it's certainly the least sexy part of AI. I don't know if I'm allowed to say the word sexy. Hopefully that's okay. Is your podcast rated?
You could say,
okay.
No, you could say sexy, you could say fuck, you could
okay,
say whatever you want.
Just checking. But like I think those sorts of concepts are at least one of the major difficulties. I think the other one is that when you look at most mature platforms, when you look at the ServiceNow, or if you look at a service provider like ServiceNow or Salesforce or any of those, or if you look at an EMR vendor and their offerings, they more or less have a roadmap of what the core operational deliverables that they want to build are. Mm-hmm. And the industry as a whole has ingested that and is now planning for and has been planning for those things for years. Mm-hmm. And I think that to some extent, we're learning about AI, hours to maybe days or weeks ahead of our customers, because we're reading a press release and I'm going to get questions about that press release later that day.
Right.
And so I have to ingest that press release, understand how it fits into our strategic roadmap of handling enterprise AI at a healthcare system at the scale that we are, and then make an executive decision with involving all the right parties. That's, if not impossible, nearly impossible in our current operating systems. So that's certainly a challenge. And that's assuming that those products are all fully disclosed. Right. Some of these products are either not designed yet or not public. So it may be both. Yeah. And I think it's very hard to build a roadmap anyway. Taking healthcare and trying to build a roadmap has always been a challenge from what I understand.
Well, and with the innovation curve the way it is today, it's harder than ever.
Exactly.
Because how are you supposed to plan something even 18 months out, right?
Right.
But give 3-5 years, yeah, right.
Just in the last 2 weeks, I think I saw a presentation today. It was great. People from, I think, Veradigm and Brigham, they were talking about how different co-working and coding assistants have become, not in the last year, in the last 3 to 4 weeks. Right. It has been completely turned on its head again. Yeah. And so people who were claiming we had a decade to figure this out just got alerted to the fact that we didn't even make it a full year from when they made that statement. Right. So it's like we have to really get on the ball. And I think I think COVID was an interesting example of how the pandemic it exhausted people in a way that just was decimating. It hurt morale and hurt spirit. And I think we're not there yet, but you can see that if it keeps going this way, that our leaders and our customers are going to be like, I thought we had this figured out. I thought I understood what you were planning to do, but now we're changing again, we're pivoting again. When is this going to stop? And it's to use the phrase, the new normal is breakneck pace.
Yeah.
It's just very fast.
Yeah.
And I think that's something that I would say is, to answer your question from a couple minutes ago, that's another challenge. Right. Probably one of the biggest.
Yeah.
Because not everybody cares about this or has the time to care about this as much as the people whose job it is.
Right. The crazy thing, though, is the paradigm of like the fact that if we don't do anything, right? Like it's almost like, thank God this technology exists, because if you look at the like McKinsey reports on like, you know, attrition that we'll see from like primary care physicians to nurses to, you know, all of that over the next, you know, 10, 20 years, like, and the number of folks in the United States that are enrolling in medical school to become primary care doctors or like, it's grim, right? So like I mean, that's setting aside like the macroeconomic pressures you guys are facing like every day, right? And it's just, that's all just to say that it is breakneck, and you know, it's an unfortunate like reality. Like we need to change the way things are happening today.
Yeah, I mean, just because it's scary to drive in an ambulance as fast as the ambulance can get you to the emergency room doesn't mean that it's not the speed the ambulance should be going, right? Like it's necessary to go that fast sometimes.
And scary.
It's
Right.
going to be scary.
Right.
And I think the wrong response is to tell those people to just deal with being scared.
Right.
And I think the better response is to
Let's talk about
summon empathy
Yeah.
and understand what's scaring them, what's uncomfortable, and taking the stance that the fact that it's inevitable doesn't mean that it has to be unenjoyable.
Right.
And like there's so many opportunities to incorporate it in educational, easy, bite-sized ways that I use this phrase a lot at work that move the needle. Right. Working in healthcare is an exercise in moving 1,000 needles, the most microscopically small amount each day. Right. That's the only way progress gets made. You're never going to move from start to finish. It just doesn't work that way.
Right.
Healthcare has never been that way, at least not as far as as long as I've been in it. And find ways that move the needle that have those secondary tangible benefits that help other people again the second time, and the secondary intangible benefits of making everybody slightly more comfortable that Right. second time around. Like it's less scary the second time you're in an ambulance, to use that analogy again, right? You understand what's going on. You understand why we're taking this path. You understand why they're doing what they're doing. And there was a great presentation in the pre-conference forum around AI. Dr. Graham, I think was his name. He mentioned that physicians, clinicians, nurses, providers are all trained in risk assessment, and they do it all the time. And I'm not going to state it as elegantly as he did, but he basically stated that it's part of their job is to quickly determine what the appropriate level of risk is needed in order to treat the patient and the situation in front of them. And that's very true. I mean, that's part of the role they play. And he said, what we need as providers is to also understand how that works in the space of AI. And so teach us more, help us make those decisions.
Right.
And I think there's a little bit of, IT has always been a little, and I don't think this isn't me talking about Carilion Clinic, but I think it's about the industry as a whole. I mean, there was even SNL skits about it back in the day, right, with Jimmy Fallon or whoever it was. But I think that it's always been a paternalistic industry where they were doing it for them.
Right.
Like they're fixing it for them. They're making the decision.
Right.
You don't worry about it. I'll take care of it.
Right. I know.
I'll take care of it. And so I think what you're seeing is, just as AI is helping to empower everybody more, it's like, okay, well, we can't empower them and then not trust them. Right. You have to teach them how to make those decisions, and that means that you're going to have to trust them too. And so it's just a different paradigm.
Yeah. All right, Trip. So last question would be, what are you most excited about for the future? So, I mean, I definitely sense some, I mean, we talked about some of the challenges you guys are facing, but I also sense some like optimism in what you've shared. What are some things that you're most excited about, either in healthcare in general, or for Carilion Clinic specifically in the next, even like in the next 6 to 12 months?
Yeah, I mean, I'll keep it broad, I think, because I'm hoping that it affects all healthcare. I'm eternally optimistic, maybe even naively so. I try not to be naive, but I think a bit of naive optimism is healthy these days. And so I'm really looking forward to getting more tools in the hands of passionate people. And I think one of the things that, my wife's in healthcare and my mother worked in healthcare. And I think people in healthcare are never short of passion and drive. And you're rarely going to take a wrong step when you give passionate, capable, smart people good tools.
Yeah.
And our tools are rapidly becoming very, very good. And I mean, they're already incredible, more incredible than they've ever been. But they're becoming safer to use. They're becoming easier to learn. And the curve, I'm an economist by training, and that's what I studied in school. And I always think about the productivity curves, how they bend, and like it's like that. We're changing the shape. We're not moving along it so much as we're really pushing out the supply curve of what's capable, what's possible. And that's a phrase they use a lot in AI education, right? We talk about the art of the possible, and it's a great phrase, and I like telling it to people because it immediately, like, what do you mean? And it starts down the question process, but the question asking process. I think what I'm most optimistic about is seeing what we're going to do when these people have it. And one of the things I spend most of my time trying to figure out is how do I get these tools in the right people's hands in a safe way so that they can't make mistakes that they're not even aware they're making, right? So one thing is, I think, to go back to that question, I don't know, so hopefully this will make sense. I know you're, these may not all go in order, but the comment about trusting the provider and empowering them to make the decisions, I think that is about teaching them how to use the tool, but you also don't want to give them, like teaching someone how to use a table saw, or my daughter's going through engineering programs, and so she has access to all these things, and they should teach them how to use them safely and how to do it and what the risks are. But that doesn't mean you give them a defective table saw. You don't give them a broken tool. You don't give them something that's poorly wired or loose bolts, right? You give them something safe. You put them in a safe environment and you educate them of the risks of just using it. And so you remove those sort of built-in risks of a bad tool. And so I think that's what's most exciting. I'm just really eager to see when we can get through some of this early adoption phase. And I've already seen some of it. We've had people come up with amazing ideas about how to streamline their work. They're building their own agents. Whether or not we can always safely deploy them is always another question. Right. But they have the ideas. And when you have someone, I'm going to call him out. He's our chief of orthopedics, the orthopedics chair at Carilion. I mean, he is just a fountain of ideas. Love and that. He wants to do amazing things with it. And it's, he doesn't know Python. He doesn't know SQL. He doesn't know these things, but he's an amazingly talented orthopedist. And he's now seeing what's possible with these tools. And I mean, we're barely scraping the surface, and his ideas are just endless. So, that's what I think. That's what I'm excited about. That's just awesome. To unleash that potential that's sitting out there, because sometimes it's held back by the cumbersome tools we have to use.
Right. No, 100%. Trip, this has been amazing. Thank you so much for taking the time.
Yeah, pleasure.
Yeah, and to our listeners, thank you for tuning in. We'll catch you on our next segment. Good afternoon, innovators. David Wright here, and I'm your host of the Disruptive Innovators Live podcast here at HIMSS 2026, sponsored by our friends at Lumen. And I am lucky enough to be joined by Dr. Kaitlan Baston. Kaitlan, pleasure to have you.
Thanks for having me. It's really fun.
Yeah, absolutely. So Kaitlan, for any of our listeners who aren't familiar with you or your work, I was hoping that just to start, you could tell everybody a little bit about your background and kind of where you come from.
Yeah, sure. So I'm a family medicine doctor by background, did medical school and residency, did addiction medicine after that. So I did an addiction fellowship. Really gratifying work. I worked for about 8 years at Cooper University Healthcare, which is a university teaching hospital doing integrating behavioral health, addiction, and primary care, really trying to pull it all together back into the health system. And it was amazing and fascinating work. And it took me into the world of policy a lot because I had to work with health and human services on regulations, kind of create new billing structures and think about that because addiction has historically been so siloed from healthcare, right? It was all carved out. You had to go somewhere else to get treated for that. And so we were really pulling it all back in. And that took me into government relations and policy work, and then working really closely with the Health and Human Services Department. I got to know the administration a little bit of the state of New Jersey and became the health commissioner. So I ran the state Department of Health for a couple of years.
Oh, wow.
And again, got to see healthcare from a totally different lens, really how the sausage is made, if you will, in all the interesting ways. And got to affect so many lives and think about health from a public health perspective, while also having what it was like to be a provider, what it's like to be at a hospital in my mind. So amazing journey. Had the amazing opportunity to run the state's public hospital then as an interim CEO for a year and really see things from that perspective, making the hard decisions. What technology do we invest in? How do we modernize healthcare? How do we make things more efficient, work smarter, not harder, all that good stuff.
Sure.
And I just exited to start my own company just because I want to keep pushing the healthcare industry forward the way I think it should.
Yeah. Well, I'm excited to talk about that for sure. It's interesting. I just got to thinking because I think Dustin Hufford had introduced us, and I'm pretty sure my mom's the president and CEO of the Center for Great Expectations, which is a behavioral health, organization in New Jersey.
Oh my gosh, what a wild world that I'm just putting this together. She and I have worked together for years now that I know your last name.
Right. So, and that kind of just came together for me as I thought I remembered it before, but then, anyway, the point being that the work that you've done and that she does in trauma-informed care and these models of care that treat the actual underlying conditions and not the symptoms of these disorders. I think it's incredibly important work. And bringing into the kind of holistic care model, I think is great. So talk to me a little bit about Vinyl Health.
Yeah. So, a lot of the time when I was in government, when I was a provider, when I was, running a hospital, I kept seeing that everybody's trying to coordinate care, right? The people your mom takes care of, the people that I took care of often have so many things going on in their lives. We all do. I'm a working mom, right? Yeah. I've got 20,000 things I'm trying to keep straight, where healthcare is a part of what we think about, but not 100% of the time. Right. And there's a lot of care coordination that happens in healthcare because it's hard to keep track of it. And our system it's not very straightforward. One might say it's a little broken. Right. And so I really wanted to kind of cut through that a little bit. I think, government pays for care coordinators, payers pay for care coordinators, and trying to, and case managers and trying to get people to take care of themselves the most efficient way. Right. Providers do it. Everybody's kind of trying to care coordinate for their own purposes and make things go smoother. And rarely do we actually involve patients and families in that and let it come from them. And the efficiency that we gain when people get to understand and own and really drive their care, especially when we're solving problems that are the problems they're telling us we need to solve, rather than doing 1,000 checklists to try to figure out what the real problem is. That's the solution I came in to solve. So Vinyl uses all the big technology buzzwords out there, right? Ambient AI, integration of records. Oh, wow. But it points it all at patients and their families. Okay. So it's like, hey, what if you could actually understand everything that's going on with your healthcare and you can record something like a visit with a doula, right? Which otherwise would never be integrated into the health record. Right. to, a visit you need to have before a surgery, a big peri-op, visit where you have a bunch of checkbox things you need to get done so that you don't have to miss your surgery or have anything get in the way. So pulls all of that together, helps people understand it, and then helps people share it with loved ones or care partners who are going to help them manage their care.
Wow. That's exciting. Where are you guys on? I'm just like, as you describe that, like my mind automatically goes to like interoperability or, all the things that I'm sure you guys are dealing with right now. Like talk to me about what's going really well and like what like a challenge you guys are facing.
Yeah, where the friction is.
Yeah.
I will tell you, it's a really good time to be doing this, to be starting a company. AI is blowing my mind every day.
I know,
We're an AI company, but I'm also using it in ways that I never envisioned when we created it. Really thinking about ethics of AI, really thinking about how the right guardrails help us use it to move fast and do it carefully at the same time. But it's a beautiful time to be doing this. Also, because I was in government and really thinking about integration and really pushing some of the things when I was a health commissioner with data sharing and thinking about what the federal government is doing on data sharing, and they're really aligned with where we are, right? They want patient empowerment.
Yeah.
They're pushing the CMS Tech Ecosystem, which is really making sure that people have, the golden record. They have the source of truth, and we can do that at the individual level, hence vinyl, right? The record name. So it's really the government and all this interop work that they're doing with data blocking and helping people open to make it easier to connect to TEFCA, to make it easier to connect to other portals. And it's really aligning with right place, right time for us to be able to do that and make it easier and possible for patients.
Are you guys like looking at Clear or any of that stuff?
We are, yeah.
That's cool.
Identity vendor being part of the ability to connect to TEFCA, ability to connect them with other records, and then we use QR codes to make connection as easy as possible.
Nice.
And that's really what, part of that CMS Tech Ecosystem is pushing. So, hey, just scan this and you'll see everything you need to know about me. And now we can connect on a human level and not have to just do do you have any allergies?
Right.
Right. Tell me if your maternal grandmother had diabetes,
Yeah.
Nobody needs that,
That's cool.
Yeah.
And then what about points of friction, like what you guys are needing to like overcome right now?
It's so important to me as a doctor that anything I do not only works for patients, but makes the providers' lives easier, right? And a lot of that for me is just making sure that I understand how I can make it as easy as possible to have a doctor download everything they need to know about a person in a minute, right? Which AI can enable, like I can show them that in the app, they can see that. But I need to make sure that I make that completely frictionless for providers.
Right.
And, on an individual doctor to doctor level, I talk to docs about this all the time and they're like, oh, this is great. But when you get to the system level, right, how do I make sure that the system can see this is going to save your doctor so much time? If the patient understands what's going on and what they have to do next, it's going to save your system so much time.
Yeah. Who are your customers?
So right now, patients are one big part of our customer base, right? The consumer themselves. We have a whole direct-to-consumer arm. It's mainly people who have somebody who's dealing with something big in their family, like someone who was just diagnosed with breast cancer, someone with an aging parent who they're trying to help manage their care, right?
It's a subscription model?
And it's a subscription model. So that's a big part. And then because when family members help people take care of themselves, when you have, especially if you're older, if you have a complex issue, it decreases costs for healthcare. So then it's really important for employers who, are taking care of their whole employee base, like large employers or insurance providers. But again, I just want this to be available for the doctors. I want it to make their lives easier. I want it to make their patients' lives easier. So I have to make sure that people who can't afford it can still have access to it.
Very cool.
Yeah.
Exciting work.
It's really fun to be able to solve a problem, to be nimble, to be out there in the world and give something that every time I tell people about this, they're like, hey, could I get this for my mom or my uncle? Or man, I have, my family members in and out of the hospital and we're all trying to keep the family in the loop. Between me and my brother, we can't make it to all my mom's medical appointments. Just feels like the right solution at the right time.
Yeah. And when you were talking before about the the care coordinators within a health system, the care coordinators within insurance and payer arms, like the care, we've all, I could speak for myself, like I've seen that all over the place, but it's never benefited me or my family.
That's right.
So it is a problem, and I'm excited that somebody's solving it. So
Yeah. Thanks.
Yeah.
Yeah, I'm excited too. And and that's not because there aren't great care coordinators in the world. It's because we're duplicating efforts. They're not enabled with the tools that they need. People aren't enabled with the tools that we need to really understand and navigate the system. I liken it a lot to, I'm a doctor, so I'm constantly this person who's helping interpret, I'm on the bat phone for people who, someone has to go to the hospital, someone
Right.
has something, they're like, hey, do I really need this thing?
Yeah.
They're telling me. And people need to have access to that if they don't have me in their pocket, right?
Right.
And everyone should have that access.
Yeah.
And we need to deduplicate efforts that are just really just I hate to say this, but like all the robocalls and texts and whatever, they're just often annoying and not necessarily actually getting it. Yeah, but the real barrier is X, right?
Yeah.
Like yes, I know I have to schedule this, but I'm a working mom and I just can't do it during the middle of the day.
Right. Yeah.
Like let's actually get around that problem and help people drive their own care.
Yeah. Well, I have my annual physical on Friday, so after I get the results, I might need to. Now I have your cell phone number, so I might need to call you. Now I
Better
have
yet,
a person.
I'll just give you access to the app.
Yes.
Take it into your visit.
Perfect.
Tell me how it goes. Tell me all the things about it that I need to make better, and then all the things after that to make it the best.
Amazing. Kaitlan, thank you so much for taking the time.
Yeah, thank you. And also say hi to your mom for me.
I will. And to our listeners, thank you for tuning in.